This patient was referred to me for endodontic retreatment of tooth number 30. The root canal and the crown were done a few years ago in another country. And patient recently started to have symptoms, went and saw his dentist, and his dentist referred him to us. As you can see, crown, open margins, previous root canal, periapical lucency here, and another one right here. This is another angulation of the tooth. Perhaps maybe there's something going on here, maybe a missed canal, distal canal, and this is the bite wing of the tooth. So we discuss options with the patient, and patient wanted to try to see if tooth could be saved. He's a young guy, and that's what we did. Went ahead and redid the root canal for him in one appointment. So let's go ahead and switch to point of view clinical video and go over each step. All right, so let's go ahead and start with local anesthetic. The girls had already placed the topical for a few minutes. We didn't record that part. Lidocaine is going in, lidocaine with epi. I start with that. Inferior alveolar nerve block. As you can see, my assistant is suctioning. This patient was salivating a lot. And that's something that you need to pay attention to. Some patients, they don't need to be suctioned frequently, and some patients do. So you want to make sure that your patients are comfortable at all times. As comfortable as possible. I mean, they're getting a root canal. I always tell my patients, remember, you're not at Disneyland, but at the same time, I'm going to make sure that you're comfortable. We wait a few minutes, and then I'm going to place a different local anesthetic, this time Marcaine. Marcaine I like because it's long lasting, so it lasts throughout the treatment and then for a few hours afterwards. That way the patient has time to go home and start taking their pain medication before the local anesthetic wears off. Pain-free local anesthetic administered. All right. We're gonna need to place the rubber dam and take a look here. I'm using a premolar clamp, and I'm using the thickest rubber dam that they sell on the market. These are really thick because we use chloroform, and these don't dissolve right away with chloroform if they're exposed to chloroform. If you get a drop of chloroform on them, unlike the other kind that we use for regular root canals, these don't, they're very resistant to chloroform, this solution. All right, very good. As you can see, that crown is already, take a look. You can already see it's a PFM crown, so you can already see the metal from underneath. So either patient clenches and grinds, or the dentist, when he placed the crown, he had to adjust it. It was high and he had to adjust it. Anyways, my assistant is wiping the tooth and the clamp and everything else down with isopropyl alcohol, 70% isopropyl alcohol. And I'm going to start with a metal cutting burr. I don't need to start with a round diamond burr because the metal is already showing. So I'm just going to go through the crown with a metal cutting burr. Patient is aware that he will need a new crown. That's not the crown. The crown is an ill-fitting crown, and I just went right through it, as you can see. And again, I don't use water, but I know how to use my high-speed handpiece and not fry the periodontal ligament. But if you're a new dentist and you don't know how to do it, please use water. Don't be like me. This is one of those instances that I beg you not to do what I do. I've been doing this for 24 years with no issues. So please, if you don't know how to use the high-speed handpiece properly, definitely use water. See, I don't put the burr on the tooth for long periods of time. I touch it, cut it a little bit, and then go back in again. As you can see what I mean? I'm brushing, I don't cut it. I don't put the burr on the crown for extended periods of time. That's when you heat up the tooth and you can damage the periodontal ligament. But again, I've been doing this for many years, so please use water. Don't be like me. All right, I switched to a cylindrical end cutting diamond now to remove the buildup material. Underneath the crown. And again, as you can see, I'm brushing with it. I don't let it sit on the tooth for long, extended periods of time to heat up the tooth. I don't want to do that. So definitely use water. Don't be like me. Don't do what I do. So spoiler alert, at some point, this ill-fitting crown will come out. It just wasn't fitting properly. As you saw, the margins were open and what have you. Anyways, it's gonna come out and I'm gonna have to deal with that, so stay tuned. All right, so this is what we have so far. I don't know what kind of permanent filling material that was. As you can see, it doesn't look like composite or anything like that. It looked more like temporary. I switched to a thinner diamond, end cutting diamond here. And I'm under the microscope, as you can see, very carefully removing the buildup material and enhancing my straight line access, straight line endo access into the canals. All right, so I removed the bulk, the most of the buildup material, and now I'm switching to a ultrasonic device. This is Ultramint Pro, ultrasonic unit, Ultramint Pro by 8 Teeth. And I'm using a scaler tip here to remove the remainder of the buildup material. And as you can see, I just saw a little bit of gutta percha there. So I'm getting close. All right, in case you're wondering which tip this is the P3-S tip. All right, so here we go. Look at the gutta percha. Look at the color of gutta percha. Clearly, this dentist didn't use rubber dam. So those are the two mesial canals and distal canal. Look how wet the distal canal was. Did you see that? And there was a missed distal lingual canal. The wetness came from that missed distal lingual canal. Look at that. That's it. That's a missed distal buccal canal. I'm sorry. Yep. Distal buccal canal was missed right there. And those are the mesials. Yep. You can see how wet everything is. So just in case you're wondering, oh, I don't use a rubber dam and everything's fine. This is what's happening when you look at everything under a surgical operating microscope. Your naked eyes may not see it, but when you look at everything under a surgical operating microscope, you will see how contaminated your field of operation is. All right, so chloroform goes in. Pulp chamber is filled with chloroform right now. And I'm using a number 20 flare file. You can purchase these from Manny, the company. And I'm going to try to remove the bulk of the gutta percha from the coronal part of the canals. Up and down. Push the chloroform into the canals as deep as possible and see if I can go in with I can go in as far as possible. I'm sorry, that wasn't, I thought that was a number 20 flare file. It was not. It is a number 15 C file. I thought I saw yellow, but it was not. I thought I was seeing the yellow of the flare file, number 20. No, it is a number 15 C file. I apologize. I'm looking at everything through my iPhone. So I'm not looking at the screen itself. I'm looking at things through my iPhone, and sometimes the color is different seeing everything through the iPhone versus looking at the screen. So number 15 C file is attached to my M4 reciprocating handpiece. That I'm running at 1000 RPM with torque off. All right, look, that's the distal buccal canal that was missed. You see that? There was no gutta percha in there. That's the distal lingual canal. You can see the resistance. There's gutta percha in there. So, so this dentist missed a distal buccal canal. I'm kind of moving the chloroform into the canals to allow the chloroform to dissolve the gutta percha. All right, so that's that. Number 15, I removed the bulk of the gutta percha with chloroform and number 15 C file. I'm topping off the chloroform, and now I'm going in with a number 10 C file. attached to my reciprocating handpiece that I'm running at 1000 RPM, torque off. I'm trying to go to my estimated working lengths to see if I can go with my estimated working lengths. Remember, this dentist had filled short. The canals that he had found, he had filled short. So there's a reason why the canals were filled short, and you can see why they're blocked. Perhaps by debris and pulp tissue, leftover pulp tissue. Clearly, this dentist didn't know how to do a root canal properly. By the way, this is the same patient that I presented last week, Wednesday. We redid the root canal on tooth number 19 together, remember? The patient from last week. So this dentist clearly didn't know how to do root canals properly because we had to redo tooth number 19 also. So I'm going in with my apex locator. This is Fine Pex apex locator by 8 teeth. All right, very good. Let's see what the working length is here. And I'm going to give it to my assistant. My assistant will read it and tell me what the working length is. And then I'm going to move on to the next canal. I just added a little bit of chloroform. I don't want the chloroform and gutta percha mixture to kind of dry out because chloroform evaporates, as you know. All right, this is a number 12 C file now attached to my reciprocating handpiece. I'm trying to see if I can go through that blockage in the mesiolingual canal. Yeah, blocked. I'm not pushing, I'm not forcing the number 12 C file here. I don't want to perforate. That's the missed distal buccal canal. And as you can see, he didn't mess with that one. And the file goes in pretty smoothly. This is the lingual canal. There was a little bit of gutta percha in there. It's like a single cone that we were able to dissolve in chloroform and go through. And now I'm regaining patency in the distal lingual canal. This is a number 12 C file attached to my M4 reciprocating handpiece that I'm running at 1000 RPM with the torque off. Up and down, up and down. When you run it at 1000 RPM, this reciprocating handpiece or any reciprocating handpiece, when you run it at a high RPM like I'm doing, it not only helps you with the instrumentation and shaping of the canals, it also activates sonically whatever fluid you have, whatever liquid you have in the canal, in this case, the C solution. I'm reconfirming the mesiobuccal one more time. So mesiobuccal is patent. Mesiolingual is the one that's blocked. I'm going in now to the exact working length that I determined earlier with the Fine Pex apex locator. Making sure that I'm going through the blockage and regaining my patency. Remember, the mesials and the distals, for that matter, where they were instrumented and obturated short. Plus, of course, the distal buccal was completely missed. All right. What's that saying? Measure twice, cut once. Again, I'm reconfirming my working length, just to make sure. Confirming and reconfirming when in doubt. Again, I'm giving the file to my assistant to read the measurement and give me the number, the working length. I just touched the rubber dam clamp just to make sure that it was stable. My assistant is suctioning for the patient, as you can see. All right, number 12, C file attached to my reciprocating handpiece in the mesiolingual canal again. Just trying to see if I can bypass that blockage. The mesiolingual canal is blocked. Brushing motion up and down, up and down. Going to my working length now in the mesiobuccal canal, up and down with the number 12 C file. Not pushing it, don't want to perforate. I just let it go, glide to where it wants to go if it wants to go anywhere. Up and down, pushing the chloroform deeper into the canal. I'm working on the mesiolingual, as you can see. And I have some progress. Take a look. The file is going deeper. And this is all chloroform right now. All right, number 10 C file in the mesiolingual canal. Let's see if I can go to my working length. I know the working length for the mesiobuccal. I used FindPEX apex locator to determine that. So I'm kind of almost certain that the mesiolingual canal will be pretty close to the mesiobuccal number. Yeah. I'm almost through the blockage. Remember, you need to know how to do these properly because, I may make things look easy, but this is 24 years of experience and practicing on thousands of extracted teeth. So I may make it look easy. So don't think that it'll be easy like that. So don't be just watching my video and going straight to a patient. Patients don't pay you to practice on them, remember. Patients come to you because you got a doctor before your name. It doesn't say trainee and then your last name. It says doctor. So they pay you believing that you know what you're doing. So practice on extracted teeth, as many as extracted teeth as you can get your hands on. Practice every day. Practice, at least practice 2 or 3 times a day on extracted teeth. 10, 15 extracted teeth a week. And keep going, keep practicing. Yep, I'm almost through the blockage. This is a 10C file attached to my reciprocating handpiece. And take a look, I'm almost going to my working length that I achieved in the mesiobuccal canal. So I'm going to that working length. In the mesiolingual canal, that was blocked. No more. Blocked, no more. There you go. Regained patency in the mesiolingual canal also. There you go. Very good. Very good. If you don't know what you're doing, you can easily separate that 10 file. This is a 10C file. So again, I may make things look easy, but you're looking at someone with 24 years of experience. So practice on extracted teeth. All right, let's measure the mesiolingual now. I'm using the fine pex apex locator by 8 teeth. Has to be pretty much the same as the mesiobuccal measurement. You know, maybe 0.5 millimeter to 1 millimeter difference. Make sure you also remember your reference point. All right, reference point is important to remember. I'm using the mesiobuccal cusp of the crown as my reference point for the mesials. I'm trying to get a stable reading with the apex locator. All right. This is what we have so far. Add a little bit more chloroform. Top it off. All right, I need to work on that mesiolingual some more. So I just had my assistant remove the stopper from a 21 millimeter C file, number 10 C file, because I want to go to 21 millimeter. I believe the mesiobuccal working length was 20. So I want to go to 21 millimeter, and I just did. Reference point being the mesiobuccal cusp of the crown. All right. Remember, if you go 1 millimeter, 0.5 millimeter to 1 millimeter longer, in such cases, it's okay. You're not damaging anything. Remember, there's periapical radiolucency there. So it's not like you're damaging the periapical area. All right, let's go ahead and measure the mesiolingual again now. All right. Seems like I got a stable reading. So I already regained patency in the mesiobuccal, regained patency in the mesiolingual, located a missed distal buccal, and of course removed pretty much all the gutta-percha by dissolving the gutta-percha in chloroform. All right, so this is isopropyl alcohol, 70% isopropyl. I'm irrigating the pulp chamber and the canals with it. How the heck do I get rid of this now? It's like it should go away on its own when I put the cursor back here. All right. So mesiobuccal was 20. So I'm going with my number 12 C file attached to my reciprocating handpiece to my working length, which is 20. Mesiolingual is 21, so my assistant just removed the stopper. 21 millimeters from the mesiobuccal cusp. Very good. Distal buccal, that was missed and we located, is going to 21. Distal lingual also is patent. And this, again, this was isopropyl alcohol. All right, now I switch to 6% hypo. That's 6% hypo now, irrigating copiously with. All right. Number 15 C file attached to my M4 reciprocating handpiece in the mesiobuccal, that was 20. Mesiolingual was 21. I'm running the number 15 C file attached to my reciprocating handpiece at 1000 RPM with the torque off. I'm not only instrumenting and shaping the canals, I'm also activating the 6% hyposonically. Distal buccal, distal lingual, also patent. There you go. Just activating the 6% sodium hypochlorite, trying to remove all the remnants of gutta percha and leftover pulp tissue and what have you. Now my assistant is giving me a cotton pellet soaked in 70% isopropyl alcohol just to clean everything. Gutta percha and chloroform mixture is very sticky and he latches on to canal walls and pulp chamber walls. So this is one way of just making sure that all the gutta percha remnants are removed. Just wiping everything down. So this is what we have. Again, I don't know what kind of material this dentist used. The gutta percha seem to be the same gutta percha as we use. Perhaps maybe some kind of I don't know, maybe a sealer was different or what have you. Just like tooth number 19 that we retreated last week, you can see the red staining. The dentin is stained red. So whatever material this dentist used caused the staining. 6% hypo. And now this is my flare file, okay? Number 20 flare file. I'm brushing with it, as you can see, up and down, brushing with it away from furcation towards the line angles, appropriate line angles. Brushing. Distal buccal. Distal lingual. Remember, it's called a flare file for a reason. You just flare with it in a brushing motion. So I'm not trying to go to my working lengths with this thing. If it wants to go with ease, I'll let it go, but I don't force it. All right? I don't force it. I don't force any files. If they don't want to go, I don't force them. Practice on extracted teeth. Don't ask me, how do you do it? How do you do it? You've already seen how I do it. It's now your turn to practice on extracted teeth. How many times I can verbally tell you how to ride a bike? At some point, you need to get on that bicycle and learn how to ride it. You already know all the didactics. You already know all the theory. So you just need to now get some extracted teeth and start cutting dentin. 6% hypo again. Take a look. Look how nice and clean everything is right now. Number 15, C file. Attached to my reciprocating handpiece that is running at 1000 RPM with the torque off. I'm pushing the number 15 C file even in the mesiobuccal canal that had a working length of 20. I'm pushing a number 15 C file to 21. It's okay. Remember, there are periapical radiolucencies associated with this tooth. So I like to, with the smaller files like 8, 10, 15, I like to go a little bit deeper beyond the working length just to agitate that granulation tissue in the periapical area. 6% hypo again. Pay attention to how I irrigate with the needle, irrigation needle, side venting irrigation needle, and the 6% hypo. I don't let the needle bind to the canal walls. All right, so this is what? Super Flexi Gold. All right, so all right, so these files, Super Flexi Gold and Easy Shaper files. You can get them from flexivodental.com. flexivodental.com. They're great files. And these Super Flexi Gold. Orifice opener and the rest of the files. They're heat treated. They're excellent files. All right. So, and the RPM is on the package. What RPM, the recommended RPM. Again, you must practice on extracted teeth. Anyways, back to 6% hypochlorite. Irrigation. Now I asked my assistant to give me the microsuction. I want to see if the canals join. So let's take a look. Yes. So the mesials join. All right. As you can see, I removed hypo from one canal and the other canal also emptied. And looks like distals may join also. But you can see the staining, the red staining of the dentin, pulp chamber floor, whatever this dentist used, because number 19 was also had the same staining. All right, 6% hypo goes back in again, and you can see how good my assistant is, just making sure that no hypo gets out of the tooth. All right. Number 15, recapitulate. I'm recapitulating with number 15 C file. As you can see, up and down, brushing motion. I'm going a millimeter longer than my working lengths with number 15 C file. Just to ensure that the debris that these NiTi files generate, all the other files generate, they don't precipitate in the apical part of the canal, layer after layer after layer, causing a blockage. So recapitulation is very important. Recapitulate and then irrigate again with 6% hypo. Get rid of all the debris that you generated just now. So these steps are very important. These steps are extremely important. Every step leads to the next. If your one step is weak, it causes the other steps to malfunction for you. You remember, a chain is only as strong as its weakest link. All right. Going in with the next file. Again, brushing motion, brushing. That was the orifice opener, by the way. I just needed to open the orifices a little bit more. I had already used the flare file number 20 in a brushing motion, so the orifices were pretty open, but I just wanted to make sure that everything was kind of smooth. There was a smooth transition from the coronal to middle to apical area of the canals. And you can achieve that sometimes with the orifice opener, but be very careful with these orifice opener, because the apical area of these orifice opener is very thin. So if it binds to the canal, it can crack, it can break. All right, so let's go ahead and make our own custom gutta percha master cones. So here I'm using a 25 4%, and I'm putting it to where it wants to go until it binds. It doesn't want to go anywhere. I measure it to my reference point where I got my working lengths from, and then if it's longer, I cut it. And that's how I make my own master gutta percha cones. Again, practice on extracted teeth. You already know the theory. You must now practice on extracted teeth. You already know theoretically how to ride a bike, how to ride your bicycle. So now you just need to get on the bicycle and maybe fall down a couple of times. And the longer you ride it, the better you'll get at it. So practice on extracted teeth. You already know the theory of how to do a root canal. Now you just need to practice on extracted teeth. The more extracted teeth you practice on, the better you get. All right, 6% hypo. Again, goes in. I didn't like the cone fit. Didn't have a very good tug back, and the tip of the gutta percha was kind of bent a little bit. Microsuction. Little air. Doing my inspection, and look how nice and clean everything looks. You can see I've already troughed for the middle mesial also. There's nothing there. All right. I decided to go ahead and not do master gutta percha cones, and instead I decided in this case it would be a better fit if I went ahead and used the injection technique of the thermoplasticized gutta percha, because I just didn't like my tug back with the gutta percha cones that I tried. And please, I'm begging you, don't do what I do as far as the obturation goes right now. Don't use the injection technique. If you don't know what you're doing, you're gonna inject so much gutta percha out the canals that sometimes you may have to do surgery. And worse, you could literally inject the thermoplasticized gutta percha in the lower teeth into the inferior alveolar nerve canal. So please don't do what I do. I've practiced on thousands of extracted teeth. But in some cases, I use the injection technique of the thermoplasticized gutta percha, and I'm going to do it right now. Sterile paper points, AH plus sealer. I'm coating the canal walls with it, with the AH plus sealer. Again, don't do the injection technique. Don't do it. You're going to regret it. I'm trying to see if I can cone fit the mesiobuccal canal right now. I think I had a hard time in the mesiolingual canal with the cone fit. Let's see. Okay. So what I did was I put a cone, gutta percha cone, in the mesiolingual canal, as you can see. And now I'm using the injection technique to obturate the mesiobuccal canal. Remember, the mesials join. So this is a hybrid technique. I may have invented this, I don't know. I don't know, because I've never seen anyone else do it this way. But again, I do this when I don't like the way the gutta percha fits in the canal, in certain canals. All right, so anyways, system B, to remove the coronal part of the gutta percha and to thermoplasticize the remainder. Extra gutta perchas coming out. Buchanan number 2 plugger, condenser. Apply pressure and hold it for a few seconds. Apical pressure and hold for a few seconds. I don't take a cone fit working length PA, but again, I've been doing this for 24 years. I strongly recommend that you do it. If that you're more comfortable with that, do it your way. I'm just showing you how I do things, but you don't have to do other than the fundamentals, which is, of course, rubber dam and irrigation with 6% hypo and regaining patency in all the canals, and the fundamentals stay the same: 6% sodium hypochlorite, sonic or ultrasonic activation, recapitulation. Those are fundamentals. But the rest, you can make your own. You can do it your own way. All right, so I'm watching this. This case is from many months ago. So I'm watching this as it's my first time watching it. So I thought I was going to do the injection technique, but I think I changed my mind and I decided to go ahead and with the cone fit. So I did the distals with the hybrid technique. So I put gutta percha in one canal, and then I used the injection technique of the thermoplasticized gutta percha in to obturate the other canal. So distals were done that way, and the mesials now I just use the gutta percha cones. Again, I believe I was gonna use the injection technique, but I was worried because when the two canals join, the injection technique doesn't work very well because the two canals join. So the injection technique, it tries to fill two canals at the same time. So sometimes with the injection technique, you're actually ending up filling short. And I didn't want to do that. So I think I changed my mind and I said, I'm just going to cone fit. And I cone fit it. All right, so the two mesials now, I cone fit it, I cut the gutta percha, I condensed apically, and now I'm just using my obtura gun to obturate the remainder of the canals with the thermoplasticized gutta percha. I'm doing the same with the distals. All right, let's go ahead and condense the gutta percha, Buchanan plugger. Again, during treatment, I may change my times multiple times about something. And I'm constantly thinking, sometimes I'm thinking out loud because I want to make sure that my assistants are learning too. I'm teaching my assistants also. Remember, the more educated your assistants are, the better off you are. I have my assistants sometimes telling me what to do. And I'm completely okay with that. You know, sometimes your ego doesn't let you listen. But I've trained my assistants so much so that sometimes I take advice because when I'm in the middle of the battle, sometimes I don't see things as someone who's outside of the box and watching everything. So they may have some good ideas and I don't mind. For example, sometimes my assistant tells me, Doc, why don't you try this? And I'm like, okay, that's fine. Let's do it. And I do it. I have no issues with my assistant giving me an idea in the middle of the procedure. I have no problems with it whatsoever. All right, we are done. Let's go ahead and use isopropyl alcohol on a cotton pellet and clean everything, clean the pulp chamber floor and walls, get everything ready for the temporary going in. Take a look. Sterile sponge goes in for the general dentist to know when to stop drilling. Cavit goes in. And again, these were the files that I used. And you can go ahead and purchase them from flexivodental.com. flexivodental.com. All right. Cavit goes in. Very good. All right, rubber dam is out, and I think that's when the crown comes out. Let's see. Yep, that's the crown came out. Perfect timing for the crown to come out. I told you that crown was pretty ill-fitting, and patient needed a new crown, but it came out at the perfect time when the temporary was already in and everything was sealed and fine. So, yeah. And patient is well aware that he needs a new crown. We already discussed that with him. All right, so let's go ahead and take a look at the post-op radiographs. Remember, this is what we started with. This is what we started with. This is the post-op. This is one angulation. Take a look here. We're able to regain patency in all the canals. Let's look at another angulation. This is another angulation. Look at that beautiful lateral right off of the distal canal, right into that lateral lesion. Another angulation where you can see the two mesials. Look at that beautiful lateral right there. And all of this anastomosis. You can see the two distal canals. Remember, he had missed the distal buccal canal. And another angulation. Again, take a look at that beautiful lateral right there. And anastomosis. 4 canals. Again, you can see the lateral right here. You can see a puff right there. And of course, this one here. Okay, so as you can see, everything went beautifully. And I'm optimistic about this endodontic retreatment. So if you like these videos, please make sure you subscribe, you like, press that like button, you comment, you share, you tell your friends about our channel. And anyways, flexivodental.com if you like to purchase these files. This is the Easy Shaper. It's a full pack, full kit. Starts with the orifice opener and then the Super Flexi Gold. flexivodental.com. Excellent, very good. All right, so see you guys in the next video. Goodbye.